Good morning. Happy New Year, my digital pathology trailblazers. How are you today? I'm super excited. This is the first live stream in 2025. It's already the 10th of January, but that's okay because I was feeling so overwhelmed at the beginning of the year because everybody's like making resolutions and getting ready for new year and like all those goals, and I'm like, I'm still working through the backlog from December. Let me just attach this somehow so that I don't have to hold it. And I don't know, I was feeling behind, but apparently, I've heard that like some energy fields say that we're gonna start better off on the 21st. I don't know if I believe it or not, but it made me feel better. So, whenever you are joining, let me know where you're tuning in from. And I'm gonna say hi in the chat so that you know you can respond to my comments. Mhm. Hi. Oh no, wait. We can do it. Let me know if you see my comments. Comment something because I don't know if my chat is working. And I also don't know what to do with this microphone. I'm just gonna put it on this thingy. Okay, so my friends, digital pathology didn't stop over the holidays. I don't see any comments. Okay, yeah, I see comments. It's working. So feel free to let me know where you're tuning in from. Oh, guys. Brilliant device. Magnetic. Let's see. Sorry for this technical. Okay, how about now? Let me know if you hear me. Okay, and we have guests from France. Welcome. Let me know if you hear me well when I have it here. And let's dive into DigiPath Digest. I see more people on the live stream than there are commenting. So feel free to give me some live stream love and say hi and let me know where you're tuning in from. And we are starting with evaluation of enhanced ResNet 18 classification for rapid on-site evaluation in respiratory cytology. Okay, good sound, all good. Let me make myself smaller for this and get to my drawing board. So what's happening here is, of course, we have AI. Of course, we have digital pathology, but digital pathology for cytology. Let's pay attention to this because that's going to be a theme in a few more papers. And there was a video I posted last year, and the use of digital pathology in cytology, I kind of listed it as a drawback, that it's not that available for cytology. But in today's DigiPath Digest, we'll see that that's not the case anymore. In 2025, here, January 2025, cytology is entering the digital pathology space on par with anatomic pathology with formalin-fixed paraffin-embedded sections. So let's see what they did with this ResNet classification. This is a group from China, and it's interesting what's happening in China that can be extrapolated to other places that are different than the Western world and different than the US. So the objective here was rapid on-site evaluation, ROSE. This is something that takes less than 5 minutes, basically. And this is the rapid on-site evaluation of, in this case, respiratory cytology specimen. And this is a critical technique for timely diagnosis of lung cancer. So what's happening here, it's either through endoscopy, transbronchial or transcutaneous. You sample a mass, you do a cytology, and then you stain it with something called DIFQuick. It's a special staining. DIFQuick, I remember this still from my veterinary practicing days. So it's it was super quick. You just had 3 jars of different stains. You put in one for 1 minute, 2 minutes, or whatever, and in less than 5 minutes you have a stain specimen that you can evaluate. But there is, in China, there's a limited familiarity with diff-quick staining method and a shortage of trained cytopathologists, and this hampers the utilization of rows. Is that specific to China? No. I think it can be found, like the limited familiarity with the particular stain and shortage of trained anybody in the pathology space in different places in the world. So definitely we can take the learnings from China and apply it somewhere else. So they wanted to involve deep learning, because then you have an AI assistant for whatever you're doing, right? And if you're not so familiar with it, it's good to have an assistant, even if it's an AI agent or robot or whatever. And by robot, I mean software here. So they analyzed 116 digital images of diff-quick stained cytology samples, and they made whole slide scans. And actually, I was using my phone to find what kind of scanner they used. Let me see if I can check what kind of scanner they used. No, I don't see it. We would have to go into the paper, but that's not the point. And there's another paper that talks about different scanners for cytology. So if you're interested in what scanners can be used for cytology, stay on the live stream. And also, give me questions. Let's finish this paper. So they included 6 diagnostic categories, not criteria: carcinoid, normal cells, adenocarcinoma, squamous cell carcinoma, non-small cell carcinoma, and small cell carcinoma. And the thing with cytology is that you, it's like less specific than anatomic pathology. So all malignant diagnoses were confirmed by histopathology and immunohistochemistry. And then the test set was presented to 3 cytopathologists, different hospitals, and also different varying levels of experience, and an artificial intelligence system. And they say diagnostic accuracy of the cytopathologist correlated with their years of practice and hospital setting. Okay, I would assume the longer you practice, the better you are at it. So I hope it was a linear correlation, correlating better accuracy with longer experience, but who knows. And the AI model demonstrated proficiency comparable to humans, which is good, because that's what we want. Because we do want an assistant that is not worse than us. If an assistant is worse than us, then it's not a good assistant in this particular pathology diagnostic settings. And this has been shown before already, combinations of AI assistants and human cytopathologists increase diagnostic efficiency to varying degrees. So if we have an assistant, AI assistant, we're faster here. So we have a promising capability as an aid for on-site diagnosis of respiratory cytology samples, and human expertise remains essential. Also, so I see it with consumer AI. You, like, with your knowledge, you can sort through the answers. And I've been using Perplexity on my phone, like with voice commands, for the last month, over a month. And I ask it very specific questions. I ask it to search literature in specific journals, and it comes back with answers. Not all the answers are, I wouldn't say accurate, but actually answer my question. But I kind of immediately know that this is like a little bit aside from what I was asking for. And with, my knowledge, my like partial knowledge of what I'm looking for. For example, sometimes I know who the author of the paper is. Sometimes I know like one main message of a paper. So me combined with this tool is a lot more efficient than me going and searching through the classical methods that were keyword-based, PubMed, Google, whatever. Even though my assistant, Perplexity in this case, is not always like it does not always deliver me 100% of the stuff that I want. I know how to guide it. So in this case, this was obviously image-based, but was a similar thing. Another paper that we have here, we have a lot of like not really digital pathology specific, is I think it's like a beginning of the year. Let's set the stage for the situation that we're going to be encountering moving forward, which is that digital pathology and AI will be helping us more and more. I'm going to switch myself to big. The mouse is okay. Yep. So because we have a few reviews, and whoever is joining in right now, let me know in the comments, whichever platform you are, let me know in the comments where you are tuning in from. I'm in Pennsylvania, 6:12 a.m. right now, and super happy to have so many of you on the live stream. Just say hi, and let's move on. Let's get on with those papers. So the like tendency or something I see today in this particular PubMed alert is that reviews, setting the stage for AI is going to help us, digital pathology is going to help us, and also cytology is part of the game now. Don't feel if you are a cytotechnologist, cytopathologist, somebody working with cytology sample, don't feel underserved by the digital pathology community, because today in those papers, the researchers are discovering that this is doable, and cytology is part of the game as well. And that's what this advancing precision medicine, the transformative role of artificial intelligence in immunogenomics, radiomics, and pathomics for biomarker discovery and immunotherapy optimization. Yeah, I've seen this pathomics word. It's a relatively new word. I guess like the most narrow definition of this would be predicting molecular, because omics is the omics from genomics, right? So some kind of molecular properties. So deriving or predicting or discovering molecular properties in pathology images or some kind of biomarkers that can point us to molecular. So and let's see, this is where Cancer Biology Med, and this is a group from China and USA. So we have a collaboration, China, USA, and AI, our friend AI, is advancing precision medicine in the fields of immunogenomics, radiomics, and pathomics. Immunogenomics, AI can process vast amounts of genomic and multi-omic data to identify biomarkers associated with immunotherapy responses and disease prognosis. So let's see if I can highlight something super important. Multi-omics is what I want to highlight. Multi-omics is the where everybody wants to go, because okay, and we have somebody from PA. Fantastic. Hello. So it's, wow, it's super early for you as well. So multi-omics is where everybody wants to go. And by everybody, I mean the medical and scientific community, bioscientific community, life science community. Because if we can integrate all these different information, then we're so much better than just basing diagnosis on one type of information. We can detect things faster. We can predict responses to treatment better. And we need assistance of computational pathology or computational medicine tools, because so many pieces of data at the same time, it's not physiologically possible for us to process, right? I'm always referring to, okay, immunofluorescence. You see like 3 markers at a time, but to evaluate, let's say for like estimating how many of different lymphoid cells, when you have lymphoid markers are there, you have to switch those markers off. You can only evaluate one at a time. So that takes 3 times as much time to evaluate a triplex than just a single marker, right? And then, the adjustment of time to do it in a fluorescent image, in contrast to a bright field image that we're more used to. So anyway, we are very good in logic and everything, but processing a lot of data at the same time is too much. Oh my goodness, we have somebody from Australia. Welcome. What time is it in Australia? Let me know in the chat. So, multi-omics is the keyword. If you don't remember anything from this paper, remember multi-omics needs assistance of AI, and this supports personalized treatments. In radiomics, I love that, because there AI can analyze high-dimensional features from computed tomography, MRI, and PET scans as well, and like high-dimensional, literally like 3D analysis of shapes and everything, and this is very important for discovering so-called imaging biomarkers, but not like pathology imaging biomarkers, but 3D imaging, or basically radiology imaging biomarkers. So tumor heterogeneity, treatment responses, and disease progression, very much progression, because you can see how this mass grows, where it grows, what kind of shape it takes. And if this is important, then you have this data and you can analyze this data and analyze if there is a treatment response based on this. And the cool thing about radiology, in contrast to pathology, unless it's, well, radiology is, well, it's non-invasive. All right, let's say less invasive and real time. Although ROSE would be real time, but it's a little bit more invasive, depending. Anyway, radiology, usually less invasive, even though you have to go into a machine or get some kind of radiation, but a real-time assessment. And again, for personalized therapy. And our friend Pathology leverages AI for deep analysis of digital pathology images, and that can uncover subtle changes in tissue microenvironments. So tissue microenvironment in general, but specifically in tumor microenvironment, and specifically for immune oncology. If you have so many of those markers that you want to analyze, this is a task for AI. And by AI here, I mean image analysis. Oh my goodness, people at 9 p.m. Alexandra is listening to this at 9 p.m. Okay, thank you so much. I appreciate it. So pathology images, whenever we have like multiple markers to analyze, subtle changes, also multitude of changes. So there was a group from Mayo Clinic that used software Aphoria to detect a lot of different visually distinguishable features of colorectal cancer, and then they combined these features and created a prognostic model. So you can see visually each and every one of those features. They are explainable, they are understandable, and they were kind of like loosely or not so not numerically associated with prognosis, but when they analyzed them, detected them with image analysis, it was a totally different piece of information, totally different piece of value for the care of that patient. Even though it was previously already visible by human eyes, the combination, multitude of data together was something different. So also cellular characteristic, morphological features, and again, not that the pathologist doesn't see it, and the trend is to use those that pathologists actually see for predictions for everything, because then we kind of have the explainability covered, so to say. We do want to have this explainable, but combining them into insights or extracting insights from the combination that are actionable for the patient is something that we have not been yet able to do without the assistance of AI or digital pathology or computational tools, however we want to call it. Basically, computers are helping us. So again, unique insights into immunotherapy response prediction and biomarker discovery. And what do we gain? Of course, speed, accuracy, robustness of biomarker discovery, but also improved precision, personalization, and effectiveness of clinical treatments. So this is the paper setting the stage for, hey guys, embrace AI and let's leverage it for better patient care. And let me know if you have any questions. I don't see any questions in the chat. Can be related to the paper, can be unrelated, whatever comes to your mind, because there is something I want to do in the near future, which is a live Q&A. We'll see when and how often. I ambitiously am thinking about doing it once a week. Let's see about the bandwidth, but definitely once a month, where I gather all your questions about everything from the messages you send me on LinkedIn, on other social media platforms, emails, responses to emails, and in those live streams that we have, DigiPath Digest specifically, because this is where you tend to have the most questions. And I'm going to be taking those questions and answering them. If I don't manage to answer them in the particular live stream or piece of content, I will take them and I will have a Q&A session every regular time, let's say every month for now. So if you want to put it in the chat, put it in the chat. If you want to send me an email or a LinkedIn message with a question about digital pathology and AI in pathology, let me know. I will be answering those questions on a regular basis. And now back to machine learning approach to predict HPV positivity of oropharyngeal squamous cell carcinoma. This is Pathologica group from Italy, and the impact factor is 4.4. I didn't do impact factor for the other ones. I'll do it next time. So HPV status is an important prognostic factor in oropharyngeal squamous cell carcinoma. I love those abbreviations, OPSCC. Anyway, oropharyngeal squamous carcinoma and HPV is the human papillomavirus. Positive tumors are associated with better overall survival. So to determine the status, the HPV status, there's a lot you need to do to find out. So now it's IHC immunohistochemical investigation for expression of the P16 INK4A protein. And this must be associated with molecular investigation for the presence of viral DNA. So we have two. We have IHC and then we have molecular DNA detection. And then they want to do image analysis for this instead. So do machine learning, image analysis, machine learning. So machine learning would be a tool used for image analysis to predict HPV status from H&E stains, from hematoxylin and eosin. And if you are joining a little later, let me know in the chat. Oh, we have somebody from Munich. Hello. I spent some time in Munich. I worked there 3 years, 2 years, for 2 years. It's beautiful there. And I bet it's called winter now. So for this HPV status, we extracted a pool of 41 morphometric, 41 morphometric and colorimetric features. So colorimetric, I was like, oh, and if you have staining variability, why are you doing colorimetric? But maybe they had a they had a good solution to that. But this is another proof point of what I just said about the explainability situation. So they didn't like just train a classifier with examples here. They actually found out that they extracted features. So they actually defined those features. And we have somebody joining from Singapore. Oh my goodness, what time is it in Singapore? Yep, that must be some odd time as well, or maybe not. We'll see. Maybe it's already next day. So those morphometric and colorimetric features, and they were working with the TCGA, the Cancer Genome Atlas, samples and archives of pathological anatomy of Federico II of Naples, from their Italian Naples Pathology Institute. And they built a random forest classifier. And their model showed 90% accuracy. And there's a debate whether accuracy is a good metric or not. But you know what? We're not going to engage in this debate right now because we don't have time for that. And we would need to spend we would need to invite experts on image analysis, model performance metrics. I used to have a presentation on that, but this is a topic where you forget it the moment after you finish the presentation, unless you do it every day. But I'm digressing. Let's go back. They also studied the variable importance to define a criterion useful for the explainability of the model. So here we have this word explainability again. In medicine, we do want to have explainable models, and it's 7:26 p.m. in Singapore. Okay, thank you so much for joining. So yeah, features extracted, explainability, and the model was accurate. So they built a classifier capable of anticipating the result of P16 immunohistochemistry and molecular tests to assess the HPV status of squamous carcinomas of the oropharynx by analyzing H&E. So this would be something that I would call pathomics as well, because we're anticipating or predicting a status of a molecular test just from the images. And thank you so much for the hearts. I think the hearts are on Facebook. If you can show me some likes and love in form of likes, that's going to take this live stream and show it to more people who might benefit from this content and learn more about digital pathology. So thank you so much for the hearts and likes. And if you are a uropathologist, you need to prepare for a tsunami of prostate cancer. So this was also published in Pathologica, the uropathologists of the future getting ready with intelligence for the prostate cancer tsunami. This is a group from Italy, also USA and Spain, Ireland, and they were talking about that we need to embrace digital pathology and AI for prostate cancer. So another paper of those that I classified here as the beginning of the year, setting the stage for digital pathology and AI readiness. So there was a paper by the Lancet Commission on prostate cancer, and they project that now this is the prostate cancer will raise from 1.4 million in 2020, that was already 4 years ago, to 2.9 million in 2014. And I'm like, why would it rise so much? Well, it is connected to lifestyle, more earlier detection that influences the prevalence, and also, well, not the prevalence, but the detection of it, and also developing country being more and more developed, so entering this different lifestyle stage that the developed countries or Western countries already have, and have those factors contribute to prostate cancer. So they say that late diagnosis of prostate cancer, it's widespread worldwide, but especially in low-income and middle-income countries. And the best way to cope with the harm due to increase in case numbers is to develop systems for earlier diagnosis. But obviously systems, I mean, it's a catch-22. Systems for earlier diagnosis are going to detect more cases faster, which is what we want, but it means there's going to be this tsunami. So we will need to leverage AI and digital pathology diagnostics, like here, DP diagnostics, AI. And in this particular paper, they describe how digital pathology and AI can help pathologists for the prostate cancer tsunami about to come. So basically, and we know we have prostate cancer algorithms available for from commercially available from different companies. Page AI having the prostate one being the most famous that was cleared by the FDA. And in the meantime, while I'm explaining this, I'm gonna say hi. Hi, Dr. Madhu from the UK. Fantastic to see you here. But yeah, so this paper goes through what we are talking about probably every time we discuss paper or digital pathology, that it should be faster. It should give pathologists confidence in terms of like this AI assistant. So AI plus pathologists are more efficient and more accurate than AI or pathologists alone. So this tandem of AI and pathologists, which is enabled by digitizing the images, by digital pathology, is going to be something that is not going to be optional anymore. It's going to be a must if we want to provide the level of care that our patients deserve whenever we can. Anything else? Yes, the last paper today is talking about cytology, my friends. Again, cytology. Everybody who is a cytology person, now you also have access to digital pathology. And this one actually talks about all the different scanners. So if you want to know which scanners to use for digital pathology, then this paper is for you because it mentions them. Okay. And this is for thyroid cytology assist. So how whole slide imaging can assist in thyroid indeterminate cytology. This is a systematic review. So it goes through all the different reviews that they found in literature on PubMed or wherever and talks about, okay, what's going on, who used what. So thyroid cytology, particularly in cases of atypia and undetermined significance, follicular lesions of undetermined significance. And I don't know if I forgot to look for my tumor slides when I was in Poland. Shoot. Anyway, but what I wanted to tell you here is that when I had my thyroid tumor diagnosed, I had cytology like 3 times, and it was always like inconclusive. And then, at some point I had to go to surgery, but I kind of experienced this undetermined significance of a cytological evaluation of something, right? So the problem here is suboptimal sensitivity and specificity challenges, and this systematic review looks at papers between 2020 and 2023, and they used different stains. The stains, so they found 176 studies. Oh, sorry, let me just make it bigger for you. No. Here. 176 studies, 13 met the inclusion criteria, and the data sets ranged from 145 to 964 whole slide images. And we had those 494 AUS cases. ranging, so the overall number, and then ranging from 8 to 254, and 5 studies used convolutional neural networks, 2 used artificial neural networks, which is interesting because CNN is like a subset of ANN, but okay. And then, okay, so we had 5 studies and 2 studies. That's 7 studies. I'm getting a little confused in those numbers, but I bet they have it well calculated. But the methods for preparation included Romanowski stained smears, Papa Nicolau stained, or H&E, H and AMP and E. I assume it's just H&E, and liquid biopsy. Liquid-based cytology, thin prep. And let me tell you the scanners that they used. I'm going to purposefully make myself bigger here. My mouse is not cooperating. Come on, I must do it. Because then I want to make it a short for you on LinkedIn for those who are not on this live stream. So, the scanners that were used in studies for cytology include, drum roll please, Leica Aperio, Aleuda Neurointelligence Cupertino, and Panoramic Desktop Scanner. Let me show you the names. Here, Leica Aperio, Aleuda Neurointelligence Cupertino, and Panoramic Desk Scanner. And then there were different classifiers as well, and feed-forward neural networks, two-layer feed-forward neural networks, all the different classifiers that were used, which maybe they were used in combination, because we just said that they had 5 studies with CNNs and 2 studies with ANNs, and then I look at it and I see how many classifiers: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, I am confused by the numbers in this paper, by like all the different combinations. See, it's what I would do now. I would take my perplexity. Maybe I can do it live. Let's see if I can. Maybe I'll give you a demo. So let's see. I'll do it. And we have also people from Colombia. Hi, Colombia. Okay, this is our last paper, so I can do a demo. So I have this Perplexity installed on my phone, and I can talk to it. So let's see. In the paper, Artificial Intelligence of Whole Slide Imaging Assist in Thyroid Indeterminate Cytology, a Systematic Review, published in Acta Cytologica, how many studies used artificial intelligence? Let's see.
The paper, Artificial Intelligence and Whole Slide Imaging Assist in Thyroid Indeterminate Cytology, a Systematic Review, published in Acta Cytologica, reviewed 13 studies that utilized artificial intelligence in this context.
Okay, that makes sense, because we have 13 that met our inclusion criteria. And then, okay, what was my confusion? Well, the data sets ranged from number ranging from 8. Okay. Overall number, okay, ranging from 8. Oh, so this is per study. Let's see. How many overall cases of AUS were evaluated in this study?
The study, Artificial Intelligence and Whole Slide Imaging, Assist in Thyroid Indeterminate Cytology, a Systematic Review, evaluated a total of 494 cases of atypia of undetermined significance, AUS, across the included studies, with individual datasets ranging from 8 to 254 cases.
Thank you, Perplexity. Now, individual data set from 8 to 254. And then let me see, what was I confused about? The scanner is, okay. So 8 to the scanner models, we know. Okay, 5 studies used convolutional neural networks and 2 used artificial neural networks. I see that 5 studies used CNNs and 2 studies used ANNs, artificial neural networks. What was used in the remaining studies?
In the remaining studies reviewed in the paper, various machine learning models and classifiers were used. These included feed-forward neural networks, or FFNN, 2-layer feed-forward neural networks, 2L FFNN, gradient boosting trees, or GBT, extra trees classifier, ETC, visual geometry group 11, VGG11, YOLOV, efficient net V2L,
Okay, it stopped on me. It sometimes does that. But what do you think? Let me know in the chat. What do you think about this? So I do it quite a lot for like things like that. When I get confused and I like understand part of the information, and then I ask a question to clarify. So there was like, you know, a lot of data. Probably if I was reading it on my own, not talking to you, not trying to, you know, ask you for comments and all these things, I would understand. But because I was doing different things, I didn't. So I asked my AI assistant. And we have one question. What is my opinion about adoption and direction of hyperspectral imaging in digital pathology? I do have an opinion on this. So to me, this is a discovery method. So how I see about like everything in pathology and by proxy, everything in science, there's the high effort, high cost, high information methods, which is what I would classify the hyperspectral imaging as, that give you some insights that other methods wouldn't give you. And often, especially in the diagnostic space, how you work it is you like try to generate insights, and once you have this insight, you figure out how can I reverse engineer this to get the same insight consistently with the simpler method. So I see it as a funnel. Like in drug development, you have like this discovery phase where you have so many compounds, and then you narrow it down to the one compound that actually makes it to the pharmacies from the, I don't know, tens of thousands or how many are at the top of funnel. And for this discovery phase in pathology and everywhere, you use different methods. And you know, hyperspectral imaging is a lot of information, but also I consider, for example, immunofluorescence a more higher in the funnel method than, for example, bright field. Because it requires more effort. It can give you more information. So I hope that helps. And thank you so much for this question. I might include it in my Q&A sessions so that more people can get answer to this question. If anybody has any other questions while watching this right now, while watching this as a replay, let me know in the chat. I'm going to be monitoring them and collecting them into a separate document that I can later use for my Q&A. For now, thank you so much for joining, and I talk to you next Friday. Bye.